Rob Feckner,
Good morning.
Teresa Taylor,
Here.
Ruth Holton Hodson for John Chung,
Here.
Adria Jenkins Jones,
Here.
Henry Jones, Priya Mather,
Here.
David Miller,
Here.
Bill Slayton, Alan LaFaso for Betty Yee.
Please note, Mr. Rubacava, Ms. Brown, and Ms. Hollinger joining the committee this morning. We welcome you. Next is the item 2, approval of the December 18th minutes. What's the pleasure?
So moved.
Moved by Taylor, seconded by Mather. All in favor say, or any discussion on the motion? Seeing none, all in favor say aye.
Aye.
Opposed say no. All right, motion carries. Item 3, executive report. Ms. Bailey Crimmins, Ms. Lum, who's first? Very good.
Good morning, Mr. Chair, members of the committee. Donna Lum, CalPERS team member. This morning I have a couple of updates for you. First, regarding our efforts to support our impacted members at the campfire, as well as some updates with our year-end processing operationally. As you know, this is a very busy time of the year for us as we are processing year-end retirements. And lastly, I'll give you some updates regarding the remaining CalPERS benefit education events that we have scheduled for this fiscal year. It seems very unfortunate that this year I've had to start my updates with a couple of pieces of information regarding natural disasters and other disasters, whether it be in the state of California or elsewhere, where our members have been impacted. But I'm happy to say that with the experiences that we've had, our team members have been very diligent, very quick to move into action upon our notification that we have members that are in any of these impacted areas. So I want to give you an update on our more recent efforts related to how our team members have been assisting impacted members by the campfire, which is in the Paradise area. CalPERS has had a number of team members who were actually on site at the Disaster Recovery Center in Chico. Our first team members arrived on November 16th, and our last team members left this Saturday, December 15th. They remained on site the entire time, working extended hours throughout the weekdays and over the weekends. And during this period of time, they were able to assist approximately 900 members. During that, the way that they assisted them was by providing retirement counseling as needed, assisting them with power of attorneys, address changes, direct deposit forms, and in some cases, they were there to help lend some moral support. Having talked to some of our team members that were there on site, they have really expressed a lot of gratitude for the opportunity to be able to serve our members there on site. In addition to the team members that we had on site, we also have a number of team members here in headquarters and at our regional offices that have also been helping. They've been expediting services for these members as they have been seeking additional service from us. I have to say that I'm very proud of our team members and their commitment to consistently providing high levels of quality customer service, even during the busiest time of the year for us, and knowingly that the service that they're providing is really making a difference. You'll hear more about these efforts in Marcy's report tomorrow. Moving on operationally, again, as I mentioned, this is a very busy time of the year. We are working through the year-end retirements, but one of the other processes that we have is the processing of our retiree 1099-Rs. We are on track to deliver more than 780,000 1099 tax form to benefit payees for 2018, and the forms are scheduled to be released in the mail in mid to early January. We've also received over 6,300 retirement applications for December retirements. This is approximately 3 times as many applications as we process during any normal time of the year. Although 6,300 is slightly lower than the pace that we were at last December, we do know that there will be many more applications coming in before the end of the year. In preparation for the high volumes of processing, team leaders have done a lot of work to ensure that we will not have a lapse in our service level agreements, and we will ensure that our members are paid timely. Moving on to the contact center, again, very busy for the contact centers. They are preparing for what we call high volumes for first calls of the year. Generally, the types of calls that we get at the beginning of the year are centered around tax. They want to know what's happening with taxes, health changes, as well as retirements. Our team leaders have done an excellent job preparing for the high call volumes, and our team members have been reviewing all of the necessary materials and are also very prepared to assist our members during this period of time. And then lastly, I just want to give you a final update on the CalPERS benefit education events, of which we have 2 remaining for this fiscal year. We have 2 in January. The first is on January 11th and 12th in Seaside, California, and then January 25th and 26th in Cathedral City. As you know, these CBs, is what we call them, is our premier outreach for member education. And we can't do this without the tremendous amount of partnership that we have, not only throughout CalPERS, but through our third-party vendors who also play a significant role in educating our members. Just to name a few, we do have representatives from CalHR, Social Security, and others, our retiree associations. The remaining schedule for the CBs is located on the CalPERS website, and members that are interested in attending a CB are welcome to view the schedule, the locations, and we also have detailed information about what's being presented. And so, Mr. Chair, that completes my report, and I'm happy to answer any questions you may have.
Thank you. Seeing none, Ms. Bailey-Crimmins.
Good morning, Mr. Chair and members of the committee. Leanna Bailey-Crimmins, CalPERS team member. For my opening remarks, I have 3 items. The first is to share some details regarding the CalPERS 2019 Health Plan Member Survey, which kicks off in January. The second is to highlight our year and the Health Program 2018 accomplishments that were achieved in support of delivering affordable, quality health care on behalf of our members. And then lastly, what to expect from today's Pension and Health Benefits Committee agenda. So on January 8th, CalPERS will kick off the annual Health Plan Member Survey. Survey questions relate to CalPERS members' experience with their health plans for the 2018 health plan year. Members will have until March 1st, 2018 to submit and to respond to the survey. And as a reminder, members' responses are anonymous. The data is used for us to collect and to hold our health plan's performance accountable to the measures that we put into the plan's contracts, and also to report on certain population health measures that is in the CalPERS strategic plan. 2018 has been an amazing year, and we faced difficult but very important decisions. First, CalPERS adopted its first set of health beliefs. They now sit juxtaposed next to the investment and the pension beliefs, and these beliefs serve as guide for decisions today and the decisions that are yet to be made. And in the area of benefit design, CalPERS approved the PERS Select value-based insurance design. And we also expanded reference pricing program to now include pharmaceutical therapeutic drug classes, which will go through a solicitation the beginning of 2019. Both are innovative approaches to lowering cost on behalf of our members. The CalPERS teams look forward to providing you updates through 2019 on our progress. In the area of strong contract negotiations, we awarded new 5-year contracts to 7 carriers. We also did a new contract to the data warehouse that is pivotal to establishing our rates on an annual basis. And in 2018, CalPERS negotiated the lowest overall premium increase of 1.16, which takes effect this January. While some plans did have larger increases, 2018 marked the lowest increase for CalPERS in over 2 decades. And during open enrollment, our members were offered a new mobile experience where they were able to use an app to explore their health plan information, and for retirees actually to change that information, and to also change their plans using a smartphone or tablet. And in September, CalPERS made an important policy decision on the PPO excess reserves and how we annually evaluate them and apply those monies to reduce future premiums. And lastly, our employer retention, nearly 1,200 public agency and school employers. Our total covered lives in 2018 continued to grow, and we hit our target of 99% retention rate. Today at PHBC, we will be asking the committee to make a decision on regions and regional factors. CalPERS established its 5 healthcare regions 13 years ago, and currently the HMO carriers are permitted to establish their own regional factors. The CalPERS team will present a recommendation today based on 6 months of analysis, based on cost of care, comprehensive stakeholder outreach, and listening to employers and members. Any change that you elect to make will take effect in 2020. And Mr. Chair, that concludes my opening remarks, and I'm available for any questions.
Very well, thank you. Seeing no requests, we'll move on to item 4, action and consent items. Been moved by Taylor, seconded by Mother. Any discussion on the motion? Ms. Mother? Oh, sorry. Okay. Seeing nothing, all in favor say aye. Aye. Opposed, no. Motion carries. Item 5, information consent item. There's been a request to withdraw the item 5B, the population health report. And I believe Ms. Mother wishes to talk on that.
Thank you very much, Mr. Chair. So in reviewing the population health report, I note, and this is page of attachment 1 on agenda item 5B, page 1 of 3, and page 2 of 3. It looks like there hasn't been a material change for most of these chronic conditions and lifestyle risks, and even the clinical quality measures between 2016 and 2017. I recognize that there's a lag. We don't have the 2018 numbers yet, but I guess the question that I have is, how can we challenge the plans, or to really try to, at least on 1, 2, 3, maybe 5 of these, to really make a significant effort to reduce or increase, depending on which is better, the performance. And I wonder, I was just thinking that maybe some kind of competition or bonus, where if they achieve some significant reduction without negatively impacting the other measures, because of course we don't want them to just switch resources from one place to the other, but some way to really get at these, because they are just so sticky, these numbers. Anyway, so that's my question.
Wonderful question. We are dealing with members' behavior to get them to adhere to their medications, adhere to their exercise routines. I mean, you're actually asking us, and we take this very seriously as our mission, to try to continue to move for improved health. And this is a reflection of really the health of our population. What's not reflected here that might help answer the question is we did not put the 2015 data in here. So I think had we done that, you would see that it is moving. We're happy that it's not going, in many instances, it's not going up. We have, for our 5 chronic conditions, at least we've gotten some stability. Yeah. But I do like the idea of a competition, and I'll take that back. And the other thing I want to say is that I'm in the process of recruiting 2 physicians. Both of my physicians left to get promotions, so we're going to be recruiting, and this is at the core of what our chief medical officer is responsible for. And when I get that new person in, certainly this is one of their direct responsibilities: work with the plans to continue to press for greater medication adherence, greater healthy living experience, chronic conditions, treatments, et cetera. So at the heart of our clinical team is this population health dashboard.
Well, thank you. I recognize it's a very challenging problem, and that it has not been solved by any purchaser in the market, fully. So, but obviously it's sort of the core of what we want to do, is to have our members have better health status. And so I just, as one of my last requests, I just ask that we continue. I know the team will be very diligent in continuing to work on that really challenging problem. If we could turn for a moment to the HMO dashboard, and I know it's only for the large basic HMO plans. Was there a cutoff? Is there a cutoff for that? Did we say that under 50,000 members or lives, we're not going to include them on the dashboard? What is the threshold for that?
I think it really was to look at the larger plans, but we certainly can design our dashboard to include the other HMOs. There's no intent to try to have a threshold by any means, and perhaps we should take that back and look at how we can portray all the health plans.
I guess I'd leave it to you and the rest of the committee, but I just in looking at it, there's quite a bit of difference between some of the plans in their performance, and I know that they compete with each other, but I wonder if there's something that we can learn from how each of the plans is handling various either chronic conditions or managing on the clinical side that we can sort of propagate throughout our plans so that all of our members are getting the best care and we're addressing these issues. Now, obviously, some of the at least chronic condition prevalence numbers, that might just be the population that the plan has, the risk of the population. But anyway, just.
Well, we continue to make, as I said, this is fundamental to our mission, and we continue to explore new ways to incentivize or get our plans to stay on top of their requirements. They're contractually required, and
yeah. Okay. Thank you so much.
Thank you. Ms. Holton Hodson.
Well, thank you for this report. Really interesting, but 2 questions. So are the percentages higher for the PPO and PERS care in particular because they attract a sort of a sicker population, or are the treatment modalities different?
They do have a sicker population. We've been studying our own populations for years and years, and yes, there is a higher disease burden in the members who are in that plan.
The only thing I'd like to add is the average age is between 40 and 45, but it has a 90% coverage versus an 80% coverage. And so depending on if you look at the next year, if you're going to have surgery or you're going to have some kind of condition, you may elect to choose that as your plan because of the higher coverage.
Oh, right. And then the second question is that the emergency room usage for Kaiser is obviously considerably higher than everybody else. Now, is that because I recall from past discussions, I think, that Kaiser has just decided not to triage and then have everybody come in through the emergency room and then triaging versus having urgent care clinics and whatnot?
Yes, that is consistent with their model, that they want care to be delivered when it's needed. Even though it might come into the ER, it's triaged to more primary care delivery.
And in the end, is that more expensive for us, or have they figured out ways to make that care as competitive as if they had, this other urgent care facilities?
I believe it is consistent. Excuse me. It is consistent with the way they globally budget and then allocate those budgets to the different parts of their service delivery.
Just as a clarification, Kaiser does have urgent care and emergency care. We recently did a study, an integrated health care. Obviously, Kaiser is capitated, so they're bearing the risk. What we find is people go to that because the copays and things are a lot more reasonable. We find that when someone goes to a PPO, they actually end up being admitted to the hospital, and it's not just an emergency situation, they leave. So it is an interesting situation where it is more cost effective, it's easy to get to, so people use it. But in Kaiser's case, they are actually bearing the risk pretty much on most of that. I mean, out of the full thing, I think they have 98% capitation, 2% per fee for service. So, but they do, I just wanted to clarify, they do have urgent care centers, and they do promote that.
Yeah, I think it's sort of a little, it doesn't look, when you're thinking about emergency care and you see this, you assume that that's going to be the most expensive kind of care, but unless you know, in fact, that Kaiser has this other model. So thank you for that.
Thank you. Mr. Slayton.
Thank you, Mr. Chair. I want to come back to attachment 1, page 1 of 3, and in the lifestyle risks, and I presume, and the number that really jumped out at me was percentage of adults who are obese, and the number went up. We're at over 43% of the population. That's just unbelievable. I presume this is Kaiser numbers, and are they the only ones that you only have it for them because they're the only ones who are tracking that?
Yes, Kaiser considers that. When you go to a Kaiser facility, they do the height, blood pressure, weight. They ask additional questions in terms of what they look as their intake, and then because they do and they document it on the record, it comes across to our data warehouse.
Do you, in your opinion, do you think that number probably, if it were to be surveyed across all the plans, would be comparable across the rest of them? I know that's a guess, but...
We're working on how, other than self-certification, we're working on how we can get that information from the other plans. But to answer your question, yes, I believe it's consistent with the population. One of the things I would caution is that measures change based on the CDC and what they require. Like blood pressure could be going, normal blood pressure is being reduced. And so you may see some changes in the numbers as a result of some of these measures. The BMI itself, though, for obesity is over 25 inches on the waist. So it's, having been in the military a long time, keeping a waistline under 25 inches is rather difficult.
Yeah. So, but it does point out that, and the other question I had about that particular number, how does that compare with the general California population? Is there any data for that, or the United States, in terms of obesity measured by a BMI of 30 or greater?
There are benchmarks. We can take this back. I'm not prepared to answer that in terms of how we benchmark against California and the U.S., but we can certainly look at that.
Okay. The other question I had is colorectal cancer screening, which is in the 50s. Is that the whole population, or is that population over 50?
That would be the population over 50.
So we're still only at a little over 50% on the population that needs to be screened.
Yes, we're working on that in terms of some of those screenings don't, in fact, in our PPO, through Quest Analytics, we mail kits so that you don't necessarily have to go to the lab to participate in a colorectal screening. It's not as invasive, but at least it's getting the members to pay attention to that aspect of continuing good health.
Yeah, it just seems like that's an area where we just need tremendous improvement to keep people healthy. But, okay, thank you very much.
Okay, seeing no other requests to speak. Anything else on that item? Very good. Brings us to agenda item 6, the evaluation of health regions for public agencies and schools. Ms. Little.
Good morning, Mr. Chair and members of the committee. Sherry Little, CalPERS team member. Today we're going to continue our discussion of public agency and school health regions in item 6A. We brought back some of the information that you requested at our November meeting, and we took a more granular look at scenario A to create a slightly modified option that we're calling scenario A1. I believe Mr. McCollum's going to walk through that a little bit more with you as we progress. It basically breaks out Southern California into 2 regions, and that's the one that we're going to recommend. It's a Northern California region, a Southern California region, and Southern, and split in 2. In addition to asking you for a decision on regions, we're also requesting that you adopt our approach to regional factors in setting a range. Also, we do know we're going to do, regardless of whether we stay status quo or make a different decision, we're going to be renaming the way that we call the regions. We think that there's a lot of confusion about that, and I think you've heard about that a little bit in our past conversations. For example, we decided we would start from north to south and in numerical order, 1, 2, 3. Gary McCullum, our retired health actuary, is actually here for his last day, and he's going to be helping me walk through this presentation with you. So this is the last of 4 presentations in our plan series and represents a 6-month evaluation and a lot of research done by the team to measure the costs in the regions as they compare to the statewide average. Our strategy was comprehensive. We first had an evaluation of healthcare costs throughout the state. We then scanned the market and got feedback from our employers and our stakeholders to assess if changes were warranted. In July, we talked about why regions were first established and how, and we also talked a little bit to you about the challenges of them. Milliman shared their methodology that we used in first creating regions and provided the current day market scan for reference of where we should be today. We had extensive stakeholder reach out. I think you've heard a little bit on that as well. On some of the areas of concern that we heard, current themes were that the geographically based names used were a little bit confusing to our members and our employers. We heard that premium volatility from year to year significantly impacts a budget process, and it's difficult to estimate as they move forward on an annual basis. And we heard that the premiums in the Bay Area and Northern California were where the cost of healthcare is greater compared to the Southern California areas has been really challenging. So before we move on to the recommendation we're going to be speaking to you about today, I want to go back to the beginning just for a moment. 13 years ago, CalPERS decided to adopt regions, and we did it for 3 reasons. We wanted to create a stable risk pool by attracting and retaining as many lives as we could. We wanted to develop some regions that made economic and geographic sense for the CalPERS public agency membership, but provide as much stability as we could in that process. We needed regions to help retain and attract new public agencies where we're competing with other healthcare plans. So today our objectives haven't changed, but our question is, do we really have a problem that we need to solve? When we embarked on the journey in January, I'm not sure we knew that we did, but as we've progressed, I think we think we have a better solution. We knew it was time. As I mentioned, we haven't done anything on it for 13 years, and we've heard some complaints from our employers and our member agencies. We heard about high barrier costs, premium volatility, and the nomenclature of how we use our regions. And it definitely became apparent during our rate development process this year that we need to address the calculation of regional factors. With our analysis on regions themselves, we now have information on the costs of care by both county and by 3-digit zip code. We haven't had that for a while. From that, we determined the current 5 regions have lower marketability compared to each of the new scenarios that we brought before you in November. So you might ask, what's marketability? Just as a refresher, marketability refers to the cost of care, the average cost of care. It's the percentage of total covered lives that are paying between 97 and 103% of the cost of care in their particular area. The higher the marketability percentage, the more our members' premiums are aligned with their local cost of care. Today's 5 scenarios have 22% of members aligned to the cost of care. We can improve on this marketability. Every scenario under consideration today nearly doubles that, ranging from 38 to 50%. Adopting a new region model will increase our total covered lives with premiums more closely aligning them with the actual cost of care, and it'll ultimately benefit members and employers to reduce the premium volatility and overall competitiveness of the program, of the health program. For the stability and success of our program, we need both public agencies and schools. We don't want to lose them because our premiums aren't closely aligned with the marketplace. And Gary's going to talk a little bit about the recommendation that we are proposing today and present information requested in November for all of the scenarios.
Thank you, Sherry. Good morning, Mr. Chair, members of the committee. Gary McCollum, CalPERS team member. After receiving board and stakeholder input at the November meeting, taking a final look at the data, and doing the greatest good for the greatest number of individuals while still being competitive in the marketplace, the team is recommending scenario A1 as shown here. Now, this is a slight modification from scenario A that was presented last month. The difference is the separation of the southern part of the state into 2 regions. Look at the third region that we created, which is the 3 counties of Los Angeles, San Bernardino, and Riverside, and look at the cost relativity that's on this slide. Those 3 counties have an average cost relativity of 0.821, while the rest of the southern part of the state has a cost relativity of 0.914. We felt that that difference was significant enough to warrant creating the third region and recognizing the cost differences in those 3 counties. So the team considers this the less is more recommendation. By moving to less regions than the 5 that we currently have in place, we achieve the following. More marketability. The marketability nearly doubles from 22% to 38%. More population in the regions, which will improve premium stability year over year. Currently, the Sacramento and the other northern regions each have fewer than 40,000 lives. With scenario A1, the smallest population will be in Region 2, which is the southern part of the state, and that has over 62,000 lives. Now, premium volatility was one of the top concerns from employers as we talked to them. We'll also create more administrative ease for employers, and we get more total covered lives with an estimated premium increase of 3% or less. As requested, we also identified what we're calling hotspots. Now, a hotspot was defined as either a large number of lives with an estimated premium increase and or a large estimated premium increase. We identified the 4 areas shown on this slide along with the scenarios that are associated with them. Now, the Sacramento region has a large number of lives that get an estimated increase. The counties of Monterey and Stanislaus that are in the middle of the state there, they have a large estimated increase that applies to a small population of approximately 1,000 lives. And then finally, the Los Angeles region has a small number, approximately 2,700, with a large estimated increase. Now, while all our scenarios contain some examples of premium increases for certain members, it's important to note that these examples are for illustrative purposes only, not predictions of next year's rate increases. They're estimates of potential premium impacts to the 2019 premiums. Actual premium impact will remain unknown until after the 2020 rate development process is completed. And additionally, the decision you make today on HMO regional factors will influence those 2020 rates. So as directed at the November 2018 PHBC meeting, the team took a closer look at the estimated increases to 2019 premiums for each scenario. The analysis included various impact thresholds, counting the number of total covered lives experiencing an estimated premium increase between 3 and 5%, between 5 and 7%, between 7 and 10%, and then finally greater than 10%. This information can be found in detail in attachments 1 and 2 that were provided. Here is a graphical representation of the estimated premium increases for each scenario. Each bar in this graph represents one of the scenarios, and then the different colored sections of each bar represent the number of members in each increase category. So moving from the bottom to the top of the bar, if you look at scenario A, there's 112,000 lives with an estimated increase between 3 and 5%. And as you move up the bar, that top space, there's 1,085 lives with an estimated increase greater than 10%. And that applies to each of the bars. So the key takeaway from this graph is a quick look easily shows what scenario A1 accomplishes, it immediately jumps out at you that the total number of covered lives that are impacted is significantly less in A1 than in the other scenarios. So we created a scorecard for you to look at, and this slide provides a comparison of the scenarios. It shows the number of members with estimated premium increases in the different categories that you requested in the yellow. It also shows the estimated premium decreases in the green, and then finally the marketability of each scenario in that salmon color, I guess it is. So the first section in yellow is the same as the data that was on the previous bar chart. Now there's two things to note regarding estimated premium increase. First is the significantly smaller number of total lives, about 79,000, that are impacted in scenario A compared to the other scenarios. And that was illustrated in the bar graph that I pointed out. Second, the largest estimated increases in the two columns labeled 7 to 10% and greater than 10%, they total about 30,000 lives for scenario A1, about 40,000 lives for scenario A, and almost double that number at approximately 70,000 for scenarios B, C, and D. Now, the number of lives with estimated decreases in excess of 3% is similar across all the scenarios. And you can see the marketability numbers essentially double from the status quo. But there's two items not on this chart that I want to highlight for scenario A1. First is the average premium that corresponds to the average estimated increases and decreases. Now, in scenario A1, those 79,000 that are estimated to get an increase, they have an average premium of about $540, and that would see an estimated increase of about $41. That's about 7.5%. Now, those 170,000 lives with an estimated decrease of more than 3%, they have an estimated, they have an average premium of about $607, with that average decrease of about $25, which is about 4% decrease. So the second item of note is the significantly higher number of lives that are projected to fall within the 3% threshold. That number is over 215,000 for the recommended scenario A1, while the next closest scenario is A with about 120,000 lives within the threshold. So again, it's almost double the number of lives that are within the threshold. So one of our guiding principles for this study of regions was to remain competitive so that CalPERS could retain the public agencies currently in place and also attract new ones. The marketability factor of scenario A1 at 38% is not the highest marketability factor of the options, but it is a significant increase over the current number. Another guiding principle was to provide the greatest good for the greatest number of people. With scenario A1, the estimated premium increase to members is minimized, and the estimated number of members falling within the threshold is maximized. So the team is asking for a decision on regions today, and we're recommending that you choose A1. Now we move to the other decision we're asking you to make, which is on the HMO regional factor decision. As you know, a regional factor is used along with the state premium to determine regional rates for public agencies and school employers. In November, we provided 3 options for how the regional factors are to be developed. First option was to continue the current practice, which is to let the plans interpret the directions and calculate factors and provide those factors to CalPERS. A second option would be for CalPERS to provide a very prescriptive definition to HMO plans for calculating the factors, or in essence, calculating the factors ourselves. And the third option was to create a range for HMO regional factors that the health plans must stay within. So to avoid extreme regional factors and create consistency among the health plan's calculations in the future. We recommend that CalPERS set a range for the HMO factors for the plans to stay within. This will give us greater control, but it also provides the plans with latitude to respond to trends and their particular enrollment that they have. So that concludes my presentation. I'll turn it back to Sherry.
Thanks, Gary. As you can see, the team has done a tremendous amount of research and evaluation over the past 6 months, and we've been trying to bring forward the best scenarios we can for you. I want to thank Gary for coming back and doing this with us, and the team for working so diligently on this as we approach the right process again. And I want to remind you that regardless of the decision you make today, we're going to be adopting a new naming convention for less confusion and for ease. That sequentially numbers regions. We're going to start from north to south, 1, 2, 3, that sort of scenario. And that'll take effect whether region stays status quo or we make a new decision. After you make the decisions, everything will be incorporated into the 2020 rate development process, and that won't take effect till January 1 of 2020, so it wouldn't happen for the upcoming year. And as we move forward, we want to continue to proactively reach out to our employers and our stakeholders to prepare for any potential change that might arise because of this. We asked employers in a survey what they would want if we do make a change, and they just requested further communication, ongoing communication, and education about why the decisions were made. A majority responded that the early notification would be most important in their budgeting practices and administrative practices. So today, you have before you 2 decisions, as Gary mentioned. One is on regions and one's on regional factors. You can elect to make separate motions, or you can do them addressing both decisions at once. So at this point, I would like to thank you and conclude my presentation, open it up for any questions you may have.
Thank you very much, and thank you for the presentation. Also, Mr. McCollum, thank you for including the question that I asked the other day about the average, the increase versus the decrease. The way I look at it, unless my math is wrong, on average, there was a difference of $67 a month on the premiums, and now by this new addition, it's a $1 difference, which makes it more level playing field. So thank you for sharing that information. Ms. Mather.
Thank you. Well, I think this represents such a strong body of work, and I really appreciate the efforts of the entire team. I particularly find page 8, which is the scenario comparison review, really helpful in helping to crystallize the questions and factors that are before us and the decision that we have to make. Now, I have a question, and I like that you've included the scenario A1, which I think is a strong alternative. I have a question about why the team is recommending A1 versus A. What I'm hearing, and tell me if I'm incorrect in this, is that it's really because this affects the fewest number of members of covered lives. Is that the basis for the recommendation?
Yes, that along with the fact that those 3 counties that we've identified really do have a difference in relativity, and we felt that it would be most competitive for attracting and retaining public agencies in those 3 counties to recognize that almost 10% differential between that and the rest of Southern California.
Okay, because as I look at it, it seems to me that scenario A remains more attractive, even though it affects more covered lives, but the severity of the increase, the magnitude of the increase, is smaller. For the number of people who have a more significant increase is quite substantially smaller. Those getting a greater than 10% increase is about 1,000 versus almost 4 times smaller, and those getting a 7 to 10% increase is 29,000 versus 37, which is a third smaller. So, plus we get greater marketability, 40% as opposed to 38%. So I guess I'm inclined towards scenario A, actually, after reviewing all of the information that you've presented, although I do see A1 as an attractive alternative. I think the fact that I know it's 100,000 more members getting an increase, but it's an increase of 3 to 5%, which is a much less significant increase. And I have a hard time imagining that a 3 to 5% increase would prompt a departure from our plan. Although I'd be interested in your thoughts on that, if you've thought about how significant that might be for driving public agencies out of the plan.
Ms. Mothra, Leanna Bailey-Kermans. So you're absolutely right. If one of our guiding principles was for marketability, which is a reminder, marketability is the average cost of care for the members in their location and for their families, you'd always kind of go to the one that has the higher number. But we heard you at last session in November, and disruption for members is something we all have to consider. And as we were going through and talking about disruption, increases, decreases, but still reigning true to that principle, that's one of the reasons why the team had come up with A1. Mm-hmm. And in addition, to ensure that in Southern California, all things are not equal. And so to ensure that we were able to recognize that as well.
So you think that A1 will provide the most stability in the plan in terms of retention of public agencies, et cetera?
It provides, it is a 38% marketability, which means there is still room to grow. And remember, every 5 years, we're going to bring back analysis to you to see if there's anything that needs to change. So we'll always be moving towards that needle, but we also just have to really be conscious of the disruption factor to our membership.
Sure. Okay. Thank you.
Mr. Rubalcaba.
Thank you, Mr. Chair. I had thank you for all the work. It was very detailed. And I just have some questions for clarity purposes. I understand that the whole exercise, the whole debate, is to try to align cost of care with premiums. And one of the stated goals is to improve premium stability. So how would this process help stabilize premiums if I'll give some example. Like, for example, County of Ventura. In the current scenario, they're in the same grouping with LA County and San Bernardino. In scenario A1, they're into group 2. So for those people, like their document says here, and then under any scenario, there'll be increases. And total lives the number of total lives impact will be, everybody will be impacted. And under A1 will be the less, but nonetheless, there will be impact. So on County of Ventura, using that as an example, how would that lead to stable premiums if they're moving to a different group? And your memo says that the LA area has the lowest costs right now. So how would seems counterintuitive to me how that would help them stabilize premiums.
Okay, well, for the County of Ventura, there would be an impact because they would be moving from the grouping they're currently in, which is Los Angeles, San Bernardino, and Ventura counties, and they would be moving to be a part of what would be the rest of the Southern California. 13 years ago, when the regions were established, Ventura was considered to be part. They thought the best fit was that Ventura should be with Los Angeles and San Bernardino. Things have changed over those 13 years, and now it looks like a better fit for Ventura County would be with the rest of Southern California. There's going to be an impact to some of those counties that get moved from a region. We were attempting to minimize that impact on our members, and we felt that A1 did that the best. But you're correct. Ventura County would experience a 1-year change, and then hopefully would be stable after that.
But I understand. But explain how the premium will be stabilized. Let's look long term. How does this process help stabilize premiums?
Okay. The stability would come from a larger number of members within the grouping. Like I said in my presentation, currently we have 2 regions that have less than 40,000 lives, or about 40,000 lives. The smallest number of members in this proposed would be in the Southern California region, which would have over 60,000. Now, those numbers in themselves, 40,000 and 60,000, are big numbers. But when you carve them up between the different plans, you have the potential for getting down to much smaller numbers, which then create the possibility of premium volatility year to year.
Okay, I think I get it. Then, just to speak to the regional factors, I think I do support establishing a range. But how will those guardrails, if you will, be established? How will they be set? What are the criteria that will go into that deliberation?
Well, we haven't finalized the decision-making on how we would set the upper and lower limits on the range. That would be part of the process upcoming as they prepare for the rate development process in 2020, or for the 2020 rates.
And a final question. In your memo, it talks about how these are estimates on the impact because you won't know until the actual rate development process. What impact on the rate development process do you think these recommendations will have? Again, goes to the whole thing about how we're going to try to stabilize rates. So changing the size of the population to be carved up among the carriers, what impact do you think that would have on the rate development for 2020?
Well, there are going to be some members who would experience a rate increase, and there will be some members who will experience a rate decrease. The actual amount of the increase or decrease is unknown. What we did here was create a model that used 2019 premiums to provide an estimate of where those increases and decreases might occur. But it's not to be taken as a prediction of the amount of the increase that would happen.
Thank you.
Thank you, Ms. Taylor.
Thank you, Mr. President. I want to thank you guys for the presentation. I know we had a lot of questions. It seems like you got them all answered. I wanted to go over one more time. Mr. Fechner caught the numbers. I think I was in the middle of writing. For the average premium increase, and again, thank you for bringing those forward. I think the number was, the average premium for the increase was $541. Is that correct, Mr. McCollum?
It's $540.
$540. Mm-hmm. And then that's plus a $41 increase, and then the average decrease premium was $607, is that correct? Plus minus $25. Yeah, it ends up stabilizing to have really a very similar premium. And then I think why I see why A1 is so attractive. So rather than 112,000 people having a 3 to 5% increase, there's only 11,000 people. And then we only increase the between 7 to 10%, about 10,000. So that 112,000 over in scenario A, was that mostly Los Angeles area? Is that once we broke that out, that's where that stabilized that area?
Yes, you're talking about the 112,000 or whatever it is, and yes, that's primarily the Los Angeles region. Mm-hmm.
Okay. Okay, so that's how that, and wasn't it, clarify my memory, I think I heard this some time ago that when this first started, Los Angeles was one of our problem areas in terms of maintaining our pool of employees. Was that correct? Okay.
That's exactly right. They were lower than the statewide average, and that's when we experienced the first threat of exodus, and that's why the regions were created. And what our hopes were in creating the A1 scenario was to prevent that in the future. We still have a northern and southern, but we're breaking out the pieces in Southern California to really minimize the impact to the overall population.
And then my last question is, and I can't remember where you mentioned this. Oh, here, the disruption hotspots. So Sacramento ends up being a fairly large increase with a larger number of folks. Sacramento, it looks like that might be Monterey, and I forget the other two. Was that I don't know if that's broken out. Was that a more than 10% increase? Is that where that disruption hotspot is?
No, the Sacramento region is identified because it would be a fairly large number.
Of increase.
I believe the number of members was somewhere in the neighborhood of about 30,000, I think. But
And the
not a large,
increase was
but not a
3
large
to
increase.
5?
It was, I believe it was anywhere between 3 and 7.
3 and 7.
Between the 3 and 5 and the 5 and 7.
And then the other 3 spots were about the same? It was...
No,
just
the 2 spots in the middle are specifically Monterey County and Stanislaus County. There's about 1,000 members in those 2 that the model indicated would get a large increase.
A large increase?
Yes.
Ouch.
In excess of 10%.
And that's because they're rural counties, right? That's one of our biggest complaints from our folks, is the rural county prices.
That plays a part in it.
Okay.
I can't say that's the only reason.
Okay, all right. Well, I'm inclined to accept scenario A1, so thank you guys for the great report.
Thank you. Ms. Holton Hodson.
I just wanted to also add my thanks to the report and for expanding upon the divisions of the rate increases. That was really illuminating. And I, too, like Ms. Mather and others, sort of struggled between A and A1 and was landing on A, but I think given your explanation, we'll support A1. Thanks very much.
Mr. LaFaso.
Thank you, Mr. Chair. Again, thank you all for all the analysis. It's very responsive to the last meeting. In deference to a robust process, I don't think you could have gotten there without all the other stuff you did. More compliments on your process. I do like the fact that the discussion zeroing in on between A and A1. I saw the elegance in A1, and I think you already addressed this, Ms. Little, which I think the bottom line is both A and A1 take our existing north-south division and retain it, and the only remaining question is what we do within those 2 divisions. That is, both A and A1 say lose the 3 divisions in Northern California, and I'll ask a question in a moment, but it seems to me that in general the disruption from doing that is comparatively minor. And then the only remaining questions, I think you already outlined, Ms. Little, is do we retain the division in our Southern California area? I'm curious about something, especially apropos, I'm going to back myself up. Apropos to your comment, Ms. Little, about confusion on names, when you comment about a hot spot, do you mean LA County or LA Region?
Those hotspots were referring to the LA region.
And that's very important.
And the Sacramento region, but the 2 spots in the middle were the specific counties of Monterey and Stanislaus.
Got it. If I understand the table that accompanies the detail of the proposal, which is, page 36 in the iPad, my device is, attachment 2, page 5 of 11. It seems to me what's interesting is that the hot spot in the Los Angeles region is driven by the portion of the old Los Angeles, I'm going to have to say this right. It seems it's driven by the portion in the old Los Angeles region that would now be Region 3, that comes from the old Southern California region. It seems to me it has something to do with the impact of moving Ventura onto the other formerly non-LA counties, not actually Ventura itself. I'm not sure I said that very well. It doesn't seem to me Ventura's hurt much at all. It's the impact of everything around it that's really the issue.
Well, those 2,700 members are essentially in Ventura County. It is the impact of moving Ventura County from its current location in the Los Angeles region to the other southern region, which you'll notice from the earlier chart, there was about a 10 percentage point differential between the cost relativities. And so you're seeing that impact on the Ventura region, or excuse me, on the Ventura County.
Okay. The reason I came to that conclusion was that the table on the page I cited indicates that 22,218 lives have an increase of between 5 and 17%, and you identify them as from the current other Southern California region, which doesn't include Ventura. That's why I came to that conclusion.
Oh, those 22,000 members?
Yeah.
Okay. Yeah, right, those would not be Ventura only.
Okay.
That would be part of the overall structure or restructuring.
And just continuing on the same theme in Northern California, the bottom line in both scenarios, A and A1, and it seems to me that some of the most difficult discussions we've had in the time I've been around are which counties on the cusp between, say, other Northern California and Sacramento, or Sacramento and Bay Area, underscoring that we have these counties on the cusp that underscore how challenging it is to maintain the integrity of these regions, which, if I follow, suggests that the regions themselves are problematic, which is why both A and A1 say, let's. So the impact of that, it seems to me that the small impact on those two counties, Monterey and Stanislaus, which are at the southern edge of our current northern regions, plural, which would remain, not the northern edge, the southern edge of our current northern regions, plural, would remain at the southern edge of our northern singular region. And it's what we're examining in the hotspots there is this is the impact, both in Sacramento and those two counties, of collapsing the north from 3 regions to 1.
That is correct.
Okay. I mean, in grand scheme of things, it's relatively modest. I'm not going to belabor what I observed on the average premium increase, because I think that Mr. Fechner and Ms. Taylor got to it better. It seemed to me that number came out the way it did because it's a smaller denominator, because there are so many fewer people with that minor increase of 3% or so, and the denominator or the fraction is so much smaller in A1 compared to A. That's why that number as an average came out higher, not that actual numbers of people got a higher increase.
I'm not sure I followed that, actually.
Yeah, okay, well.
Not sure he did.
If I won't take up everybody's time, but the bottom line is if you go to the page, attachment 3, page 8, it's divided by total of 79,000 lives, not 153,000 lives. And if you go to the table beforehand, you see how much smaller that light shaded area is. But anyway, I'll move on. The bottom line is I think you're illustrating that you've done a good job of doubling the marketability. That is the alignment to the market, to the cost of care, and minimizing the disruption. Just moving on to the factors. Sort of a bit of a follow-on to Mr. Rubalcava's question. What's the data source for staff to define the ranges? It seems to me when we do this exercise, back the last time we did it in the current, Milliman did a very extensive study using a lot of data that was very intensive for a snapshot in time to drive this complex analysis. I guess the question I'm trying to get my head around is, are we going to have that kind of robust data to support our factors going forward on an annualized basis?
Yes, we do. And what we have are the cost relativities by county, and we can combine those and get a cost relativity for a region. What we don't have, the reason why we're recommending a range, is we don't have each individual plan's contracts with their hospitals and their providers, and then the mix that they have of members that go to those different hospitals and providers. So we can come up with an average cost in the region. That gives you a general cost relativity. For example, the Los Angeles region was 0.81 in our new proposal. So we know that the Los Angeles region is 20% cheaper than the statewide average. But the plans that are within that region have individual hospitals and providers that they're contracting with that will move their average cost somewhere north or south of that 0.81 figure, depending on their particular membership and where they're going. And so we would figure out, and this will be the actuarial office going forward, would figure out the average cost and then a range that is sufficient to allow the plans to protect their own membership and what number they need, but not too large that it becomes what you'd call absurd, which we had a couple of absurd regional factors in the last couple of years.
Thank you very much. Thank you for all the work. Thank you, Mr. Chair.
Thank you. Mr. Miller.
Yeah, thank you for the work and the presentation. And I find that you've been very responsive, not just to the stakeholders, employers, advocates of our members and us, but it seems to me that the proposal 1A, it's logically consistent, it's rational and reasonable, which to my mind are two different things, but it also, beyond just a snapshot in time with what we're looking at now, it's responsive to the changes that have been happening since we first started with these regions. It's responsive to putting us in a better position going forward to address changes in that marketplace in the real world as they happen over the next few years. And I think it makes sense to me. I think it will make sense to our stakeholders. The nomenclature change, I think, is just that seems like an obvious improvement. That, and I think moving to a model where we're actually putting ranges in for those factors in kind of a formal way, it just seems like a logical way to do things when, in fact, when we do that work, we've got to have that kind of concept in mind anyway. This kind of formalizes it and makes it so everyone's on the same page. So I support both the staff's recommendations for A1 and 1A and for moving to ranges for the regional factors. Thanks.
Ms. Mather.
Thank you. I agree with you about the absurd regional factors experience. And I'm wondering if there's some middle ground between us setting a prescriptive definition and setting a range. And if that is that we have a prescriptive definition and that the plans can come back to us with evidence that there's a need for them to, so sort of like comply or explain. Like you either accept what we've defined as the regional factor for the region, or you bring back an alternative that you can then explain and back up with data and evidence about your mix of members and your contracting rates. Now, I don't know, that might be a much more intensive process from the staff's perspective, but I guess I'm wondering if that would be a feasible solution.
That is a suggestion. I think that lends itself, though, to the potential that we would get back to the situation where we have differences, bigger differences than what they would want to have to contend with in the rate negotiation process.
But we could still sort of have the range as we will not accept anything that's outside of the range. But if you're going to deviate from our recommendation, then you need to defend it. I don't know. Maybe Sherry, you can talk about whether it's going to be an onerous task for the team to manage that. But
well, it's not so much that it's an onerous task, but I think some of the experiences we've had in the last couple of years in the rate development process have been that not all plans view things in the same ways, and for consistency and in order to also be able to validate and verify where we land, and also using that with our third-party actuaries, it makes a lot more sense to have that range. It gives the plans a little bit of flexibility so that nobody is so severely impacted. It gives us a little bit of flexibility, and it gives us better negotiating power, I think.
Okay. Well, I am after hearing the conversation about scenarios A and A1, I am persuaded that the staff's recommendation of A1 is a sensible choice, and I'm happy to make a motion for that, and then also to adopt scenario A1 and to adopt the staff recommendation with respect to the regional factors.
So moved by Mather, seconded by Taylor. We still have a couple of requests to speak, plus some from the audience. Mr. Jones.
Yeah, thank you, Mr. Chair. I am inclined to go with A1 because you mentioned that it's the greatest good for the greatest number of our members, and that's always my objective. And talking about objectives, and the objectives that you've stated for the regions, create stable public agency risk pools, reflect cost of health care regionally, retain and attract public agencies. And I've often said that when we embark upon these major policy changes or redirection of processes, et cetera, I've also asked for where's the evaluation tool? And some point in the future, this decision needs to be evaluated to say whether or not it's working as it's intended to reach these objectives. So I would like to hear what are your thinking, because you mentioned earlier that 15 years ago, we embarked upon these regions. So the question is, if we had an evaluation 5 years after implementation, will we have 10 more years of that before we make a change? So could you respond to that process,
That's
please?
a great comment, and we really did realize that it's been 13 years, it's been too long, and we have made a commitment to do this every 5 years, just to make sure that we're on track.
And that's true for many of these policy changes. I would suggest
Correct.
that we have an evaluation tool.
I also want to point out that now that we've had this rigorous model put together, it will be the same model, the same level of analysis. We went down to the zip code. We had third-party evaluation. That is what is going to be expected at the 5-year point to ensure that we're always on reflecting the greatest good for the greatest number of our members.
Okay, thank you.
Thank you. Mr. Slayton.
Thank you, Mr. Chair. Whenever I look at this, I always think that we got a big balloon and we're pressing at one point and it's coming out on the other side, but there's still X amount of air that has to be in the balloon. I'm leaning toward accepting A1, but here's my question. For public agencies, this is optional from the agency standpoint. They could be with CalPERS or they could come up with another alternative to provide adequate health care for their members. So help me understand the difference between A and A1 when it comes to two components, retention and acquisition. So acquiring new agencies versus retaining current agencies. What's the difference between A and A1 in your opinion?
So I'm going to let Mr. McCollum talk to some of this, but I would like to say that really it's truing up the cost to the actual costs of healthcare within a market, which was really the driving process when we first established regions. We want to make sure that everyone is as closely aligned with the care. And we determined that just the north-south wouldn't be the optimal solution, but just breaking that out slightly further so that everyone is true to cost, it wouldn't be fair to increase most of the Southern California area for a very small portion that is slightly higher than that, or risking losing a lot of the public agencies and school districts within the Southern California region.
Well, the difference between the two regions is the acknowledgement that those three counties, Los Angeles, San Bernardino, and Riverside, are significantly lower in their average cost than the rest of Southern California. So we felt that that difference in cost relativity was large enough to warrant that third region that we've created in A1.
So that'll help both with retention and acquisition, but we run the risk of some retention loss by those who are going to have significantly higher premiums.
Are you referring to the estimated increases that are?
Yes, I'm talking about the
at?
larger, for those populations that will have significant increases in A1, creates pressure to find alternatives for that care? Or are you saying that the cost is so well balanced that the agency is not going to find a better alternative?
Well, that remains to be seen every year, really, whether they can find a better alternative or not. But we feel that the regions that have been created here in scenario A1 best positions CalPERS to be competitive in the 3 regions that we've created.
Okay. I see one other advantage in A1 that we haven't talked about, which is, we had that situation, particularly in Northern California, where someone has, if they just went across a county line, they would be able to save money because the scenario is either your workplace or your home place, and if they drove 20 miles, they could be in a different region. So at least we're eliminating a lot of that confusion or problem, it seems like, by narrowing this down just to the 3. We have going to have fewer county border problems, as I would call them. Thank you very much.
Thank you. Seeing no other requests from the board, we have 2 requests from the audience. Ms. Duran Flores and Mr. Fox, please come down to the dais on my left, your right. Microphones will be on. Please identify yourselves for the records, and you have up to 3 minutes for your comments.
Good morning, Mr. Chairman and members. I'm Dolores Duran Flores with the California School Employees Association. We are in a unique position today. We are not in support or in opposition to any of these regions, but we do want to express some of the concerns we had. We believe that, these changes are significant and we should be on the record. But before I do, I want to thank all of the work that your staff did on this. They had a very collaborative process and they did seek our input, and for that, we are grateful. We also recognize that you are going to be making a very tough decision today. The decision you're going to make could potentially increase rates for thousands. And on the flip side, it could decrease rates for thousands. This is a tough choice, and we recognize it. Well, CSEA has tried to evaluate all the regional options, and I tell you, it was very complicated trying to overlay the current regions with the new proposal. And we're not experts, so it took a lot of time tinkering around with that. But ultimately, it was a zero-sum game, just like Board Member Slayton said. You press it here and it pops out another area. So we know that any changes you make in these regions some of our members will win and some of our members will lose. So with that in mind, we explained these proposals. We examined these proposals from the do the least amount of harm philosophy. That's where our vision was on this. My remarks are going to focus solely on scenario 1A, since that is what is being recommended by staff today. Taking the numbers from your charts, we see the estimates that 173,000 people are going to get premium increases of 3% or more, averaging $25 a month. But on the flip side, you're going to have 79,315 people receiving a premium increase of at least 3%, averaging $41 a month. The greatest increase we've seen are in the band of 7 to 10%, followed by the 5 to 7% band. And the 41 is, nearly double what the decrease is with 25. And we've seen that some of the premium increases from staff we've discussed, they could go as high as 35%. We also know that the 216,000 members will see a premium increase up to 3%, and we thought maybe that number should have also been included in the increase side. These numbers are just estimates again. They're based on the 2019 premiums. So in 2020, when this is actually effective, the rates actually could be higher. So it's like an add-on to what our members are going to see. And the decrease in premiums could actually be less. So based on this information, we don't see any compelling reason to adopt any of these regional scenarios at this time. It does not pass our do the least amount of harm philosophy. The number of people who will see a premium increase is just too staggering for us. We would recommend that actually you maintain the current regional model at this time. But if you decide to adopt one of these regional changes, we just urge you to take this year to educate all members enrolled in CalPERS healthcare. This way, they can prepare for the potential premium increases and
Your time
decreases.
is up.
Thank you.
Thank you. Mr. Fox?
Thank you very much, Mr. Fechner, members of the committee and the board. My name is Mark Fox. I'm the Director of Human Resources for Solano County, and I disagree in part with the previous speaker from CSEA. CalPERS, as you've heard from staff, as you've heard from me last month, has a very long history of these regions. And last month, I asked that you consider Region 1. This month, I asked that you support the staff recommendations, support the motion from Member Mather, and support 1A. It makes your marketability of the program better. It improves the regional setup that you established 13 years ago. Staff has been very open and has had a number of commitments made and honored to a variety of stakeholders. The stakeholder group that's most impacted is obviously the public sector group, the public agencies, whether it's schools, as in the prior speaker, or myself as part of counties and special districts and cities. So I think 1A accomplishes your goal of being fair to a variety of employers, being fair to the participants in the plan, and being fair to CalPERS itself in terms of trying to have a plan that is continuing to honor the goal of the PEMCA program, continuing to be as open and as marketable, and the numbers from staff show that this proposed option 1A achieves those objectives. I ask that you support the staff recommendation and the motion before you. Thank you very much, Mr. Fechner.
Thank you. Seeing no other requests to speak, there is a motion before us. All in favor, say aye. Aye. Opposed, no. Motion carries. Thank you. Brings us to item 6B, State Legislative Proposal. Mr. Brown.
Good morning, Mr. Chair and committee members. Danny Brown, CalPERS team member. This agenda item is asking for your approval to sponsor legislation to make some technical and minor policy changes to the statutes that CalPERS administers. I'll just briefly highlight three of them. First, while it might sound intuitive that if you go out on a disability retirement or an industrial disability retirement, that you couldn't come back and work as a retired annuitant doing the same job duties or job that you were disabled from performing. However, the law doesn't expressly state that. So this proposal will just kind of expressly prohibit that situation. It doesn't prevent you from returning or working as a retired annuitant. It just prevents you from working as a retired annuitant in the job that you retired from on disability. The next one would clarify that if you retire and you choose unmodified allowance or return of your contributions upon your death, that you can make a change if you have a qualifying event such as marriage. And then you can choose a new beneficiary and a new optional settlement. This one will just clarify that this qualifying event of marriage is a marriage after retirement. Again, very technical, clarifying change. And then the last one would just clarify that all schools would be considered one employer when a school member converts their sick leave to service credit upon retirement. So this would mean all school districts, community college districts, and the county superintendent. This aligns with the education code, which allows school employees to transfer their sick leave when they move from one employer to another employer. These last two changes we really feel are clarifying and are consistent with existing practice, so they would have no impact on members. And with that, I'm open to any questions you may have.
Thank you. Ms. Mather?
Thank you. So I think this is a sensible proposal. Just a question about marriage after retirement. Does that also include a legal partnership, like a same-sex that's not an actual marriage?
Yes.
Yes, so the language is clear about that?
We'll draft the language because the qualifying event includes a marriage, and I think in our statutes a marriage includes domestic partnerships and also any type of marriage. So I think we've changed the definition of marriage in our Pearl. Anthony can correct me if I'm wrong, but
Okay.
it will make sure that it includes all of those, both those situations.
Terrific. Well, with that, then, I will move staff's recommendation.
Second.
I noticed Anthony nodding his head, so you must have been right.
Okay.
All right, it's been moved and seconded. Mr. LaFaso.
Thank you, Mr. Chair. Just to clarify this marriage issue, not to open up a thing. So if I understand correctly, the way back to the 1999 bill that added registered domestic partners to the CalPERS program and the long, challenging history of the evolution of same-sex marriage in our state over the last 20 years. The CalPERS statutes contain registered domestic partners and a marriage. And though we struggled between the Bear versus Lewin decision and Proposition 8 and the U.S. Supreme Court decisions between our pre-Proposition 8 marriages and our period of legally recognized out-of-state marriages that were legal in California under the Leno bill, the bottom line is you're either a legally married individual in California, regardless of the gender of the two partners, or you're a registered domestic partner under the 1999 statute, and that's to whom this applies. Do I understand correctly?
That is correct.
Thank you very much.
All right, thank you. Seeing no other requests to speak, all in favor of the motion say aye.
Aye.
Opposed, no. Motion carries. Thank you. Item 7A, summary of committee direction. Ms. Bailey Crimmins.
My microphone doesn't want to agree with me today. I did take note, it wasn't necessarily board direction, but there are improvements with the population health dashboard, so we have taken note of that and talked about competition and obesity. So I have no board direction, but I have noted that I will be making improvements in those areas.
Very good. All right, thank you. Brings us to 7B, public comment. I have one request. Mr. Behrens?
Chairman Fechner, members of the committee, I wanted to take this opportunity to commend the CalPERS management team who sent several of CalPERS staff up to the Paradise Fire to work and find our stakeholders up there that either were receiving a hard check and that check was burned up, or receiving direct deposit, the bank burned up, and did an outreach to these stakeholders. 90 of my members were affected by this fire, and helping them through that, the financial part. The other thing I want to commend them for is reaching out and establishing through Walgreens the ability for the stakeholders to continue to receive their medication in a timely fashion. Much of was left behind because they only had time to get in their car and run or just run. So again, this kind of an outreach and this kind of a service to our stakeholders, I think, deserves a hand, and I want to thank them personally, and that's all I have to say.
Thank you very much for your comments, and we all certainly thank our staff for working very hard.
There you go.
Difficult times, and staff did a great job, so thank you, and thank you for your comments, Mr. Behrens. I want to please note for the record that on item 6B, Ms. Adria Jenkins-Jones is abstained, so please note that for the record. Seeing no other public comment, this meeting is adjourned. Everybody enjoy your holidays, and performance and comp will start at 10:15. Very good.